Lalit? So you do, ma'am? I said that's the road to health in India, and that's the block. Well, that's the drive from Bareilly to Nainital. If you watch carefully and you try and see, there's a crane there which is trying to lift that boulder out, which for all practical purposes is impossible. So let's try and see how we move today for this partnership. I'm going to do something is not just keep it to cancer, but I'm going to try and make it to non-communicable disease. So it'll be easier to handle this as a partnership because we have to learn how to go piggyback. Okay. So our aim of what we are going to do today is going to save 3 billion people by the year 2025. So let's all be serious and try and get into what I'm trying to do right now. And the second part is 2.2 billion lives will be improved actually within the next 5 years. So now before I start up, let me ask my august audience out here, how many of you all heard of Avon? Avon, A-V-O-N, it's a cosmetic company. What do you know about it, ma'am? Any one of you all can stand up and tell me, what do you all know about Avon?
Hello, it's a cosmetic company and they are into different kinds of moisturizing lotions and lipsticks and perfumes and
Perfect.
which are sold by people and lot many.
Thank you, ma'am.
Yeah.
But there's something that you did not add. They have an army which is called Avon's Army. You're absolutely right. They have something called Avon's Army. It's an army that actually leads clinical research, clinical care in Western world. How unfortunate, isn't it? Avon is there in India, but we don't have an Avon Army in India. We don't have an Amway Army in India. We don't have an Oriflame Army in India. So let's see if we sometimes can get them into our army because this is what is required by them. Okay? So next, get on there. We are supposed to be the bowl of pharmacy. We give the world 35% of its drugs, all right? But the majority of our own people can't afford these drugs. Okay? And then it is because you'll find out majority of our patients are paying all drugs out of pocket. I'm just giving you all the background. We'll discuss it on this background. 80% of them do that. And what happens is you'll find out if there's a major catastrophic illness in the family, 30% of the population actually, of those who get involved, actually some of the other tend to lose out and have their bank balances wiped out. And this has been proven by the national survey. And please remember that 85% of India's rural population is more susceptible. So whatever we are going to talk about partnership is going to be based, keeping in mind that 85% and that people who cannot afford it, who live below $2 a day. Just to tell you all, that's how our thing looks like, and we are one of the highest payers of out of the world pocket. And please look at it carefully and find out that, but young voters, this was taken up from them. They said health is the most important thing they would look at. And they would look at this in future but when they do an election. Anyway, I'm going to jump this slide and I'm going to come here. So good partnership is what we can do to improve health. So what do you think is good partnership, sir? Let me start with you. And with whom? Who are your partners and with whom?
So ideally, when you look at it, when you look at a partnership, it is partnership between the patient, because, and we are not talking about only oncology, but it's overall, the patient should be at center, partnership between the consultant, partnership between the pharmaceutical industry, partnership between the support groups. So when you look, and partnership with the family, because that's also very, very important when you look at partnership.
Lalit, whom do you think are your partners?
I think, sir, he missed the government part, which again needs a strong will and wish. If government is supporting some project, that can be done. Take example of pulse polio, which is with the help of NGO, but government is fully supporting. Take example of AIDS, HIV AIDS. Government is so much putting pressure that HIV and AIDS is gradually going down. Take example of other infectious disease including TB. Government is putting a lot of energy, but the government does not have energy or it is not in preference. So I think other than what he described, is government which needs a good partnership.
Okay. Ma'am, what about you? What do you think is a good partner?
I think the most important partnership is with the community that any hospital is situated in. If the community has a certain, you need to take what is the essence of that community needs. According to their needs, if that hospital-based is able to provide, then I think you're doing a lot of service.
Anyway, ma'am has gone off into a different realm, a more relevant realm actually, and that is public health. Without public health. And without having a communication problem, you cannot have a public health. Community has to take place. I agree with you. And as I said, health literacy.
Pardon?
Health literacy, health awareness, health knowledge is the backbone to all of it.
See, it's not just in cancer, but has, like I said, it
Yeah,
can be
I agree
in
with you.
all lifestyle diseases.
Sir, what about you? What do you say?
Actually, when I read the topic, it says to create partnerships, government agencies, hospitals, pharma,
Right.
diagnostics, and NGOs.
So perfect.
Ultimately, what I personally feel is there has to be a meeting of mind. Who are you dealing with from any one of these? If they don't work on the same wavelength, nothing works.
Sir, if any one of them don't work, it's not going to work. If any one of them don't
them-
work, the partnership will not work. So all these are
Partnership is a meeting
stakeholders.
of minds. Has
They
to-
are, they are all stakeholders. And each of the stakeholders is going to be providing health, and of health, we are talking of cancer. I think we have from pharmacy Biocon someone here. Can you come up here so I can use you as a sounding pillar? And I think there's somebody from Mitra Biotech, which is a lab. If you can come up here, because so I can take you as a pot shot at you also as a lab. Come. So now we have all the stakeholders except the government. Except the government, everyone is a stakeholder out here now. Who's there? Ravish, please come in. I didn't notice you. The resident from Assam government, come. Debashish, please. So he's from government. So now we have all the stakeholders. Government shall come here, right here. Because that's going to be the hot seat. That's the hot seat. Thank you, sir, for reminding me and for forming the full panel now. So we formed the panel. So let's start with this. Our patient population, majority low income, 2/3 below $2 a day, 50% rural, 70% are immigrants into the cities and the semi-urbans, and they are worst off. Semi-urbans are worst off even than rural areas. And then finally is 15% insurance, 36,000 annual income, high prevalence of obesity, diabetes, and hypertension, drug, alcohol, and tobacco are common. Does the government accept this?
Totally accepted.
We accept this. So anyway, I'm going to ask the government, what are our plans for increasing the insurance to this patient? Because at the end, the bottom line or the triple line is going to make a difference. How are we going to improve private insurance? How are we going to improve government insurance, sir?
Could you please come again?
We need to get this 15% of insured population going into the realms of something around 70%.
Right.
Assume that 20% of this rise in 50% is going to come from private insurances. What's your plans to get them in? And 40% is going to come from government's own insurance system of Jan Suvidha, Jan Ashudha, whatever it is, or the new systems of healthcare, right? So what is the system that you're going to be driving, sir? Because at the end, we have a dichotomy here. You can plan for health, implementation is state. So can we hear a bit of that, sir?
Okay, very, very relevant question. And my answer could be disagreeable to people around here, but answer this with all humility and also with knowing fully well that it may not be the right answer, but I'll tell you about the government of Assam, which I represent, what we are trying to do. Not only in case of cancer, in case of other things. You must have recently heard the Tata Group of Hospitals, the Tata Trust, coming up with 19 cancer hospitals in Assam. So it is a national policy which has been taken over. Our policies may be criticized, I do agree. But then the point in taking those 19 tertiary cancer centers, we call it a wheel and spoke model. And what we are trying to do there is Assam, especially infamous for head and neck cancer cases. We are trying to penetrate into the villages, equip and in terms of insurance, I'll come to that. Because I need to give you the background. Because how will they be funded, right? So 40% stakeholder will be the government. So we are requesting, we are going to different forums, requesting private insurance companies, the LIC of India to come, and in that, the entire population of Assam is supposed to be insured, right? This is a proposal, what we are trying to do. In terms of, and there are different categories, non-communicable disease this much, normal disease this much. So this is the amount which the government is planning, following the instructions of the government of India. So when I speak about the things planned by the government of India.
You'll accept that as an answer, the government's method of trying to increase the insurance part of it. I take it, it's a good answer basically. And I think that's quite a sensible answer, reasonable answer, that government is trying to open up partnerships.
It would be very wrong to say that, it would be wrong to be biased and say that we are trying to do so much. It's very little, I do agree.
So every small step is going to lead into a large step.
Thank you.
Every drop is going to form an ocean.
Thank you.
So let's not get away from that part. But then I'm going to ask you something. Why haven't you ever thought of that something like, say, the tobacco companies? They have a huge turnover. They have a CSR. You have laid down a percentage of that, right? Why don't you tell them to put that percentage into building respiratory centers, cardiac centers, and cancer centers? 3% of the turnover of, say, the Wills company would be something, a huge amount of money. I took a... No, that the answer has been given by the government of India. It's an agriculture crop, and the government earns close to around about 86,000 crores. Ma'am, I'm not getting into that argument because I know of a very close friend who paid the price of having fought this, and I know of a couple of health ministers who had to lose their job because of this. So we shall not go into this.
I would not be competent to answer that because that would be fishing in troubled waters.
Anyway, I'll tell you, in Assam, there's a bigger problem than smoking or tobacco, that is chewing raw betel nut. Anyway, let's get into it. And people who are asking questions, they were making a statement. How do we get to this in between you and the NGO? This is the term. How many of y'all have heard of this? Called patient navigator. Can I start with you, sir? No, I'm going to start with him. You, sir.
Ideally, in India, specifically when you look at, when you're looking at the majority of the patients, which are from the rural part, because urban, it's a different navigation in toto. But when you look at a rural navigation specifically to a cancer patient, it's mostly in a terminal stage.
Well, keep it. Lalit, do you have an answer? Who is a patient navigator? What is a patient navigator?
The ground healthcare worker, so the ASHA worker or the Anganwadi worker, if they can be sensitized about the cancer-related symptoms of anything, they can probably escort or refer this patient.
Ma'am, can you?
I think we should start with the young, the next generation. If they are learning or having the knowledge of what cancer can do at a preventable level, I think you have caught the next generation. I think that's very important.
Can you give me an idea what's a cancer navigator?
In a smaller setting, for example, in a hospital, the patient navigator are my counselors because the doctor doesn't have the time or patience to explain anything. So they are actually my immediate people who actually navigate the patient's journey through the medical care.
I'm going to
outside
read
of
out
the
from a
community.
WHO manual of how to have cancer care in the country, and this is what it says. Patient navigation can be the core model of the care, and who are these? They are trained, culturally competent healthcare workers who work with patient, families, physicians, and healthcare systems to ensure patients' need to be appropriately and effectively addressed. Unfortunately, in India, we still don't have patient navigators in any cancer hospital, including my own. And I think we need that. We can do it. The government has still got Anganwadi workers. We need to just train them.
The government has done much work on this front. In fact, we know about it because they are going and training all those workers, Anganwadi workers, and they go and do a survey of all and the entire household thing, and they feed in the data, and the data is been thrown up. So that's a live data which is available. Which is
So
being
I
done by the
think
government.
this is a place where all NGOs can work. Let's get hold of these Anganwadi workers, take a permission from the government and train them and get them aware of cancer and where to take it forward from there. So what do? They do everything that we talked about in the first session, second session, and in the morning what was there. They're supposed to do all of it. Unfortunately, we didn't talk about them throughout the whole day. That's what it is. And now I'm going to come down. The access support system. So I'm going to start with our pharmaceutical company. How do you intend to give drugs?
When you're talking, it echoes. We can't actually.
Okay. How can we give drugs cheaper to patients as a pharmaceutical company? What's your plans? I'm asking you, ma'am. You're the only pharmaceutical person out here.
All right. Thanks for the opportunity. Actually, if we see, I'll focus on where I am existing at this moment in time. So biologicals are basically the treatment of choice and the best treatment targeted when we talk about for cancer. So they are very expensive treatment modalities. So bringing a quality medicine in terms of global approvals, we bring the biosimilars to the floor, and that's how we increase the accessibility as well as the affordability to the patients. So there is a huge difference between the innovator and the FDA-approved biosimilars.
So fine. So drug access can be made affordable by trying to actually develop drugs differentially costing for differential part. But I don't think government will ever accept this differential pricing. That's going to always be a problem for the governmental end, so we'll have to work this out, again with the NGO help, how to have this differential pricing. Now let me ask you, sir, let me ask you. I am always worried of quality laboratory data, and I'm always worried about the right costs of laboratory data. Can you throw some light on how you can make it more affordable to patients?
Yes, question on how to make the laboratory data more affordable and higher quality. And that is where it is working on the quality aspect with partnerships. Some of our team helps work hand in hand with the regulatory bodies of the India government to understand whenever we are NABL certified, for example, what type of auditing processes occur to ensure that we're able to prove that we do what we say we're doing. So on the quality aspect, it's making sure that we're working hand in hand on what type of things are looked for in a quality audit, and then that we follow the process. Now on more affordable lab tests, what we are doing is that merging of technology. We're seeking ways where automation or artificial intelligence can come in and help us with our analyses and some of our data and communication flow and some of that type of administrative overhead. And then we're able to transfer data in a more seamless way and do analysis through integration of the artificial intelligence. That allows us to focus on the science and on the hands-on lab work where we're handling those delicate pieces of tumor tissue that come from each patient. So we are working on ways where integrating automation technology where it makes sense.
Okay.
So then we can focus on care where we don't move the human aspect out of the lab. And then that's also helping us drive down some of the cost, which of course we will pass on and to the patients. Also working with like the new Modi Care bill that passed a couple months ago. How does that look and how can we work with nonprofit, Modi Care, and with what we have to offer, focused on the patient?
So I'm going to interrupt. Okay, fine, he's finished. Let me just tell you in simple language that he put up is to have a central lab which will do the quality control, will have machine learning and artificial intelligence to control quality and keep it up to date and ready working. And then train people in the periphery, so you have peripheral labs who can actually keep doing that and matching it with the central lab. That seems to be a reasonable method. Does the panel have any suggestion to make more accessible treatment? Sir, not you, ma'am. It's from.
So when you look at access, it's not only access to medicine, it's access to everything. I feel in this entire journey, all of us together can make that happen. The government can do a bit in terms of supporting it by insurance, jacking up the insurance. The pharma companies can look at reducing the cost, because with the generics coming in, with the biosimilars coming in, the cost of medicines goes down. Then in terms of the NGOs, they can also play a very important role in making, clubbing both this, because this is a partnership which they have to lead it. So they can play a critical role with the government and the pharma companies and bring them on a common page.
Right, Lalit.
I think, sir, one more addition to whatever is being discussed. The one act was there, Drug Price Control Act, because ultimately
Right.
it is the government which controls the pricing.
Okay, you have said it. I'm back to you, sir, again. What do you think of the DPC or Drug Pricing Control Acts for controlling drug prices? How successful will we be at it?
It is very much like watching going to a foreign film festival. Can I explain how?
You need subtitles.
Right. What happens is, I'll tell you, the government comes up with a certain policy. And take, for instance, you are, I need to show myself when I say this. Take, for instance, it's a very pertinent question. Take, for instance, you're watching, you've been to an international film festival, I'm trying to demonstrate what the government tries to say and what the general public or the target audience understands. It's a Japanese film, and the hero says, lots of sound and fury, and the subtitles will say, Itana pyar karta hu tujhse, shadi kar le mere se. Okay? Now, an East European film, if you don't listen to what I'm saying, I'll bloody cut off your head. Look at the tone of the voice and what it is saying. That is what happens, sir. Big difference. When we aim it, when it is decided, it is done with a lot of planning. We, from the government side, we come up with a lot of sound and fury. But the manner in which it is interpreted, the manner in which it is implemented, there is a lot of difference between what we plan and how we execute.
Perfect,
I
sir.
have to agree to it. Thank you.
As I said, implementation is a huge problem because we haven't learned the art of implementation. Ma'am, you have anything to say about accessible?
I wanted to say that I think it's important that all doctors are hospital-based. We should be using generic drugs and not imported ones, which is 5-10 times more. We should stick to the generic drugs that are available, which are just as good and much more cost-effective.
Okay. Stop here, ma'am. I'm going to go to Lalit. Use generics whenever possible is going to bring your cost down by 60%. How sure you are of all generics quality, Lalit? A single drug can have 30 generics, and I call them garage generics.
You are asking about the quality, sir?
I'm talking about generics.
Generics, we are using more than 90.
Yeah, I'm talking about multitude generics. How do you choose one of them? You may have the same drug made from 10 different companies. I'm asking you, how do you choose them generally?
There is no clear way, sir. At my center, we usually choose it based on the pricing factor mainly, because most of them are from good companies.
I've got it. Anyway, I've got your answer. Sir, you have any answer?
No.
Okay, perfect. Yeah. Okay. So before I'm going to end up, I'm going to show you all this. This is before Dr. Chan, who was the last director of WHO. This was a statement made. Giving out free drugs would not help the poorest part of Africa, which is poorer than India. Or the government trying to give and say, I'm going to give you 1 lakh of rupees to treat it. Cancer, you come there, or 2 lakhs, I'm going to give you a patient, and you try and put up a district center where you want to do it. You cannot do it, he had told BBC, and he gave the reason for it. He gave this reason for it is by saying that the flow of money might stop, and if the flow of money stops, the treatment stops. So he suggested actually treatment should be accessible. And that is the access that I was talking in the morning, that we must have a right to health. India is a signatory to this declaration of WHO of right to health. We haven't implemented it yet. Anyway, the last bit I'll show you, that what happens when you don't plan properly, and this is not taken from India. This is taken when I worked with Penn Medicine University, basically in in Kenya. Just watch what happens. You see that that is the price of common breast cancer drug treatment that you can do, right? When you add trastuzumab, it works out to be how many times more? And do remember something, trastuzumab in metastatic situation does not cure. And when you have a fixed budget, watch this graph carefully. This is where government is caught, where we all have NGOs, we all doctors have to help the government. Watch this very carefully, that 3 drugs, which is meant to be used only in 15%, actually took away 60% of the available resources. It sounds very funny that how can you say this, what you can do. The reality is money in India is limited. Government spends 3 rupees per person per day, per month for a year, which is 1,098 rupees. It cannot spend more than this. Multiply this by a factor of 1.2 billion and you will see the amount of money government is spending. We need to supplement this with our own help by being judicious. So I think that's the most important thing, because if you do health literacy, you will wipe out 40% of cancers. So I'm going to stop here, not continue anymore, because I can continue for hours on this, and tell you all that we have reached a time to make a promise to ourselves. And this promise has to be made to us to deliver. So I'm going to end up by making a statement which I learned when I was a child. For making the cure more grievous than endurance, my good Lord, forgive me. For placing science above common sense and knowledge above wisdom, my good Lord, forgive me.